Good morning. So I'll be presenting the benefits of stroke treatment delivered on a mobile stroke unit compared to emergency medical services, which is a best MSU study. I'm presenting it on behalf of Dr. Grotter, who was unable to make it here today. So I should start by saying the mobile stroke unit is really a team effort, and this starts with our donors. We are PCORI funded, and despite this, all of our group outcome data we've remained blinded to as investigators. So the PCORI started in 2016 and has funded us $6 million over the 6 years to answer the simple question: if I have a stroke and I call 911, am I better treated on a mobile stroke unit versus emergency medical services? And the specific aims of the study, which I'll describe a little bit more later, really look at how much less disability will a patient have at 3 months, and what are the health utilities or cost effectiveness of operating a mobile stroke unit, and patients for which are followed up to 1 year. And we're currently on track to finish enrollment by May 31st of 2020, at which point there'll be 1,000 patients enrolled in at that time. And mobile stroke units don't need to be fancy. It typically involves a standard 12-foot ambulance. It has a portable CT scanner, which we now have the capability to do CTA. We have point-of-care laboratory testing, and we have both telemedicine as well as on-site people, which includes a vascular neurologist, a registered nurse, a CT technician, a medic. And there's two different models in which a mobile stroke unit can meet a patient. We utilize the Rendezvous System, which allows one mobile stroke unit to cover our entire city. So over a 2-year period, we saw almost 300 ischemic strokes that were treated with TPA on our mobile stroke unit. This averaged about 3 per week. 50% of this was treated by dispatch, which had a median about 7 miles from our mobile stroke unit base. The other 50% were treated by this rendezvous model, which occurred about 13 miles from our base. And really, when we do the rendezvous model, we meet the EMS team en route to either the primary or comprehensive stroke center. And really, this allows us to treat about a 26-mile diameter, which covers about 75% of Houston's population. And when we've looked at the times to see, rendezvous model really does not delay EMS treatment, and it shows by similar alert to TPA bolus times for both groups. In terms of the outcomes associated that are being looked at the best MSU study, we look at first at disability, which we're utilizing a utility-weighted MRS at 90 days. We also look at healthcare utilization and costs associated with a mobile stroke unit. And the costs include the cost of actually operating the mobile stroke unit, including the staffing and the training, as well as the cost to the patient. And the cost of the patient is both at hospitalization, at discharge, as well as the lifetime costs, which we will use with modeling. In terms of the primary outcome, for those not familiar, it's really by the mean utility-weighted modified Rankin score that we're looking at 90 days, and this was the primary outcome used in the DAWN study. The utility-weighted MRS assigns a value to each MRS, which is depending on the patient's value of that level of function. So lower MRS scores reflect less disability, are given really proportionally higher weight than those with higher MRS scores, which reflect more disability. And by adjusting for their baseline MRS, we can also include the effect of treatment in patients with pre-existing disability who were excluded from previous stroke trials. In terms of the sample size, our study is powered to see a difference of about 0.07, and that's with a sample size of about 1,000. So this is just a graph depicting prior endovascular and stroke trials. We're powered to see less of a difference than the NINS trial, but more than the PROACT trials. We involve over 7 sites. In Houston, we started in 2014 with a PCORI funding in 2016. Colorado and Memphis were 2 of the first sites, and we've included both West and East Coast, UCLA, New York, Indianapolis. In terms of the study process, it begins simply with a 911 call. EMS is dispatched immediately to the scene. The MSU will either be dispatched to the scene or rendezvous with the emergency team. And we do this mobile stroke unit versus standard management alternating weeks. It's staffed 8 a.m. to 6 p.m. During our standard management weeks, our mobile stroke unit meets the EMS squad on arrival to the emergency departments. That way, patients are screened and enrolled in the same way. And this just shows that with the earlier treatment with these patients, we've been shown more rapid improvement. This is a figure depicting data. It's both standard management and mobile stroke unit groups combined. It shows the association of improvement of NIH as compared to their time from their symptom onset to TPA bolus. And really what it shows is every data is a patient. So the more change that you see are patients that are treated or seen in the first hour. So this is a change in NIH from the time that the patient is loaded on the mobile stroke unit to the time that they're seen in the emergency room. And really, this happens the more the earlier this was seen. Looking at more combined data, we know that about a third of our patients are treated within the first 60 minutes. So combined group data, it's about 20% of patients are treated within the first 60 minutes. And of those 119 patients, about a third of them are mobile stroke unit patients. Furthermore, if we look at outcome data in terms of thrombectomy, we've seen on average that our onset to groin puncture time for the standard management and well as mobile stroke unit groups combined is about 2 hours. This was very alarming to us, particularly for the mobile stroke unit. So we've evolved our process to include the CT head, which is the data I presented on Thursday of how we can capitalize further on a mobile stroke unit. And it's involved to include a CTN board, which we've seen does not prolong the MSU on-scene time dramatically to offset the reduction that we've seen in the door-to-puncture time. In the same parallel processing system, we've allowed the pre-hospital notification of the endovascular team, as well as alerting the emergency department team so that there's no duplication of efforts by the stroke team or emergency department upon arrival of the patient. And this has allowed us to have a direct endovascular suite workflow process for the mobile stroke unit patients. In terms of reimbursement, the mobile stroke unit costs, it's about $500 per transport on average for a patient. In order for the mobile stroke unit to be adequately staffed, equipment, we calculate that we would need about $1,000. For CT, right now we are not billing for CT, but they can be billed both by the technical and professional fee. In terms of drugs, we are currently not billing for TPA, but that is, hopefully we will be able to at some point. And in terms of consultation, we will be able to pay for it with telemedicine codes. So bottom line, there's going to be enough billing to cover the costs associated with a mobile stroke unit operation. And with that, I will end, since I'm over time.